Well, there's always a lot going on in the treatment of cutaneous malignancies at ASCO. And this year, I was very excited because, in addition to seeing a lot of progress in the treatment of melanoma, which we always do, we also saw a lot of big data come out around the treatment of cutaneous squamous cell skin cancer, which is actually almost as common in terms of the number of patients with significant morbidity or mortality worldwide. And so this is a very important issue. So for cutaneous squamous cell skin cancer or cutaneous squamous cell carcinoma, there were two large phase 3 studies, which we finally saw the results from presented this year at the ASCO annual meeting. Um, a lot of times these types of studies are presented during the melanoma and skin cancer session. These were actually presented during the head and neck session. So it was, I think it caught some of us by surprise. The first big study was the Keynote 630 trial. This was presented by Jenny Lee. This is a randomized controlled trial, phase 3, a study looking at resectable high-risk cutaneous squamous cell cancers. So these were tumors that had been resected surgically, met very specific criteria for high-risk disease. They were treated with adjuvant radiation, and then patients were randomized one-to-one to get either adjuvant pembrolizumab for 1 year versus placebo. And there were about 225 patients treated in each arm. The primary endpoint was looking at recurrence-free survival. And secondary endpoints were overall survival and safety. And so there was a median follow-up of about 28 months. And what they saw was that at 2 years or 24 months, the recurrence-free survival rates were 78% with pembrolizumab and 68.6% with placebo. And so this did not meet its primary endpoint. The hazard ratio was 0.76. And then the 2 year overall survival rates were also pretty similar, 87 versus 90%, and a hazard ratio of 1.47. And then, of course, toxicity, grade 3 toxicity rates were higher with the pembro arm, 7% versus about 3%, and discontinuation rates were about 5% versus 1%. So unfortunately, this ended up being a negative study. And so this really kind of hit home with this point that adjuvant pembrolizumab probably is not helpful in patients who've got high-risk resectable cutaneous SCC after radiation. So that was the first big phase 3 study. But immediately after that, Danny Rishin presented the CPOST trial, which was almost the exact same study. So it was really interesting to see a contrast in results. But similarly, a randomized controlled trial, phase 3, again, resectable high-risk cutaneous SCC, patients treated with adjuvant radiation. And in this study, they were randomized one-to-one to get either cemiplimab at the standard dose for 1 year or placebo. Now, the primary endpoint for this study was disease-free survival. And then there were secondary endpoints that included overall survival as well as freedom from recurrence and safety. And so again, with a median follow-up more than 2 years, when we looked at the 2 year disease-free survival rates, there was a pretty large difference. It was 87% for the arm treated with cemiplimab versus 64% with the placebo group. And there was a really striking hazard ratio of 0.32. So this was a very positive study. And as you'd expect, the safety profile very similar to what was seen in the other study and consistent with what we know about these therapies. But at the end of the day, this is a positive, large phase 3 study. And really, we think it's practice changing and will, at least in the US, very likely lead to FDA approval for adjuvant cemiplimab. This is very important because in this disease, we don't have any approved agents. These patients, we've seen them time and time again. They present with really bad, tumors that are very morbid. They can have regional lymph node involvement. They can really suffer from their disease with a lot of quality of life issues. And we know that in the advanced metastatic setting where they don't benefit from surgery, cemiplimab and PD-1 therapies are really life-saving and life-changing therapies. So to be able to use them earlier and hopefully prevent recurrences um, will probably really dramatically change things and improve outcomes for these patients. I'm very excited about that in the treatment of cutaneous squamous cell carcinoma. Well, we still need additional agents that we can use in the treatment of cutaneous squamous cell carcinoma. We've had some experience with EGFR targeting therapies, and um, and so that's an area that's being explored. There was also a randomized control study looking at the combination of an EGFR inhibitor together with a PD-L1 blocking therapy. And that study clearly showed that there's a benefit to using EGFR inhibiting agents, but which regimen to use, which specific EGFR targeting drug, I think some of that still needs to be teased out. And then going forward, there's been a couple of other studies as well looking at intratumoral therapies and other approaches. But we really need to sort of nail down what's the kind of other drug of choice to use in this disease and identifying which therapies to use for patients who don't benefit from PD-1 therapies. That's sort of the big unmet need still. The other big thing that's coming along in cutaneous SCC is, aside from adjuvant treatment for high-risk resectable disease, is neoadjuvant therapy. We didn't have a lot of data presented this year at ASCO, but there have been at least 3 or 4 fairly large prospective studies, and there's an ongoing one as well being run through the NRG. And I think what we'll eventually start to see is that the neoadjuvant approach is probably much more impactful. We certainly know that it improves surgical outcomes, and this is important for a patient population where they're already frail. Maybe they've already had a lot of surgeries and surgical morbidity. And I think it's going to probably translate into improved outcomes as well. It's hard to say that now because it's so early and we don't have those large prospective randomized studies yet to prove it. But most of us in the field are seeing really incredible outcomes using neoadjuvant immunotherapy for cutaneous SCC. So hopefully that will be soon to follow. So as always, there was a lot of great data presented across 2 different oral sessions for melanoma at the ASCO annual meeting. And I think there were at least 2 phase 3 studies which I'd like to highlight. The first study was the Relativity 098 study that was presented by Georgina Long, or Rela 098. So just a little bit of background. In the frontline metastatic setting, we know that most patients need some PD-1 based therapy, and that's typically either PD-1 monotherapy, PD-1 combined with CTLA-4, or PD-1 combined with LAG-3. And PD-1 combined with LAG-3 is one of the newest frontline metastatic therapy that we've been using, and that's based on the Relativity 047 study, which compared nivolumab with relatlimab, that's the LAG-3 inhibitor, versus nivolumab PD-1 monotherapy alone. And so the Relativity 098 study is looking at the role of adjuvant Nivo plus Rela compared to Nivo alone. And we've seen that the adjuvant therapy approaches for high-risk resectable melanoma have, over the last about 7 or 8 years now, we've looked at a number of approaches, and all of our prospective randomized studies so far have shown that PD-1 therapy has kind of been the benchmark to go by. We no longer use CTLA-4 monotherapy, and prior studies looking at PD-1 combined with CTLA-4 did not improve outcomes and only just added toxicity. So the goal here was to find a regimen that might be more effective, but with reasonable toxicity. So this was a randomized controlled trial, phase 3. Patients had to have resectable stage 3 or stage 4 melanoma. It was a very large study, over 1,000 patients. They were randomized 1-to-1. more than 500 patients got the combination of Nivo-Rela, and then again, the control arm was Nivo, so another 500 plus patients. And the primary endpoint was recurrence-free survival. Secondary endpoints were overall survival and distant met-free survival. But at 2 years, the 2-year recurrence-free survival rates were almost the same. It was 62% for patients with the combo and 63.6% with Nivo alone. And the hazard ratio was 1.01. So that really did not meet its primary endpoint. So this ended up being a negative study, unfortunately. But we do know that there's more toxicity when we use Rela-Nivo compared to Nivo alone. And so I think this study continues to highlight that PD-1 monotherapy is still kind of the adjuvant therapy of choice for patients with stage 3 and stage 4 melanoma. So not practice changing, but certainly practice reaffirming for us. And we'll continue to use PD-1 therapy as a single agent, probably in the adjuvant setting for the time being. Now, the second study that I'd like to talk about is a study we've seen data from this trial already before, but we have longer term follow-up. And I think this is such an important study, and so one that, it's such a unique design and one which I'd like to really highlight. And that's the DreamSeq trial. This was presented by Mike Atkins. And so previously, in the era where we had two different approaches for patients who've got frontline metastatic melanoma that's BRAF V600 mutated, the prior two options for us were always immunotherapy and targeted therapy. And with immunotherapy, we knew that we could see really excellent outcomes using PD-1 plus CTLA-4 combination therapy, or similarly, we could see really good outcomes using BRAF and MEK targeted therapy. But the question always was, should we give immune checkpoint blockade first, or should we give targeted therapy first? And how would the sequence affect things? So when the DreamSeq study, this was a randomized controlled trial, phase 3. Patients were randomized into two different arms. The first arm was you get Ipi-Nivo first, and then you switch to BRAF-MEK at the time of progression. Or conversely, in the other arm, you got BRAF-MEK first, and then you switched to Ipi-Nivo. And so in prior presentation of this data, Dr. Atkins reported a 2-year overall survival rate favoring the use of immunotherapy first, then targeted therapy in that sequence. And the improvement was really striking at 2 years of 72% versus 52%. So that's a 20% improvement. And so the great thing at this meeting was, with further follow-up, Dr. Atkins was able to present 3 and actually even 5-year outcomes from this trial. So we've got median follow-up now in the ballpark of about 5 years. And the 5-year overall survival rates when using immunotherapy first, or the immunotherapy arm first, was 63%, and that's compared to 33% in the targeted therapy arm. So that's a 30% improvement at 5 years. I mean, that's really striking. And he pointed out that essentially doubles the 5-year overall survival rate. And then looking also at 5-year progression-free survival, this also favored the immunotherapy arm first at 39% compared to 13% for the targeted therapy arm first. And so, yeah, almost tripling the 5-year progression-free survival. So really striking. And for many of us who, we kind of treat melanoma exclusively, we sort of understood this to be the case. We know that targeted therapies are always a good salvage option and one that will retain its efficacy even in later lines of therapy. But immunotherapy first is really important because you can really find these durable responders, and we know that that's just so important for long-term outcomes for these patients. So this reinforces that practice. These were practice changing, and I think we will continue to cite this study for for many years to come. And so Dr. Atkins has done such a fantastic job. This was a cooperative group study, and so it was very important to lead because I think otherwise we wouldn't have been able to answer this question otherwise. Yeah, as I mentioned, there were so many studies presented this year, and there were actually a whole slew of studies looking at neoadjuvant approaches. And so far, we've had two really big randomized studies. That's SWOG 1801 and then the NADINA trial. The SWOG trial, S1801, really looked at the use of neoadjuvant, or I would say perioperative, pembrolizumab for patients with resectable melanoma. Clearly showed a survival, an event-free survival benefit. And similarly with NADINA, that used ipi-nivo in the neoadjuvant setting compared to adjuvant alone. And so both of those two studies clearly showed that neoadjuvant therapy has an important role. Biologically, it makes sense, and that we shouldn't just have patients get upfront surgery. So at ASCO this year, there were a number of phase 2 trials and smaller trials looking at various combinations, most of them PD-1 based, some of them with other checkpoints, but some of them also with intralesional or intratumoral therapies. And a lot of them are showing promise, and there's a lot of excitement that's being generated. But I think for the time being, it's just my takeaway would be that that's a field that is going to continue to advance and continue to be studied a lot. But this year, nothing really practice changing yet. But keep an eye on it because I do expect that there will probably still be more progress made there. Well, I think going forward, as much as there's excitement around the role of the immune checkpoints in treating our patients with advanced melanoma, there are still patients who don't respond to those therapies. There's arguably maybe almost half of our patients still who will not benefit or not be really cured or treatment free when using these approaches. And so that's very challenging for us. And I think we have to look at potentially kind of new, or I would call them adjacent approaches, other approaches that kind of help us modulate the immune system in a different way to gain control over these tumors, or sometimes if these tumors are less immunogenic, how can we convert them and make them hot and more immune responsive? And so I think from what I'm looking at, I think there's maybe kind of two exciting trends in terms of other approaches coming out. The first I would highlight is cellular therapies. We certainly know that the FDA already approved autologous TIL and Amtagvi or lifileucel last year. And that's an approach which we know can be very effective in salvaging patients after they've already failed checkpoints and almost every other therapy. And so looking forward, there are a number of different groups trying to build on that TIL-based approach or cellular therapy-based approach. There was a study presented. We were actually one of the sites participating. That's the Obsidian study. Their agent is called OBX115. They presented their data from the multi-center AGNI-01 study. OBX115 is an engineered TIL. It's not an autologous native TIL. It has regulatable membrane-bound IL-15. And what's exciting about this drug is instead of being primarily driven by IL-2, it's driven by IL-15, and that can be regulated or it can be turned on and off using this small molecule drug, acetazolamide, which is, a diuretic. It's used for altitude sickness, and it's safe and it's well established and inexpensive. And so last year at ASCO, phase 1 single center data was presented by Dr. Amaria, and they looked at dose escalation and explained their experiences. But this year, there was an oral presentation by Dr. Chesney, and that looked at the first 11 patients treated on the multi-center study. And while some of the patients were treated using the the dose escalation phase, there were 6 patients treated at the recommended phase 2 dose, so the full dose. And aside from the use of the regulatable interleukin-15, this study is also interesting because they're trying to look at other ways of improving on the standard TIL approach, meaning that patients don't have to have surgical resection of the tumor. They can actually have biopsies done. And then instead of the full dose of lymphodepletion used with Amtagvi, with this approach, they can actually get lower doses of lymphodepletion, which is believed to be just as effective. And then, of course, there's no need for high-dose IL-2. So the hope is that it's going to be safer. But when they looked across all the different dose levels, the response rate was 36%. But with the 6 patients who got treated with the recommended phase 2 dose, the response rate was 67%. And this is in a refractory population. So hopefully very promising activity. It would be nice to have a new TIL that's even better than autologous lifileucel. So that study continues to enroll both at our center, but also around the country. And it's starting to gain some steam and interest, and will be very exciting to see how that does. I'll also point out that this study is also recruiting to lung cancer as well, another area of huge unmet need. So yeah, so I think that beyond what we've seen with TIL so far, this idea of engineered and modified TILs going forward might also be something to keep an eye on. Besides the cellular therapies, I think also besides the cellular therapies, I think also intratumoral therapies is something that's also gaining a lot of buzz. And last year, the IGNITE trial was presented at ASCO. This is a phase 2 study, global registrational trial of patients with PD-1 refractory melanoma. There were 140 patients. They got treated with PD-1 plus the oncolytic virus RP1. And this was an intratumoral therapy that could be injected into superficial lesions as well as deep lesions, but they had to have failed prior PD-1 with or without CTLA-4. The response rate presented last year is about 33%, with a median duration of response lasting over 30 months, and promising 1, 2, and 3-year survival rates of about roughly 75, 64, and 55%. And so this year, so the primary data had already been presented, the primary analysis, but this year at ASCO, there were 2 different posters. There was one by one of our colleagues, Tricia Wise-Draper, and she presented safety data, really demonstrating that this is a therapy that similarly to TVEC is easy to manage. It is rapidly cleared, and it's really only detected at the injection site of RP1. And then we also presented a poster, and this poster did a sub-analysis. It did a deep dive amongst the patients who had been treated on IGNITE, looking at 2 different questions. The first question was, is there a difference between patients who get only superficial injections of RP1 versus deep injections? And then also, is there a difference between lesions which are injected with the virus and lesions which are not injected with the virus? So most of the patients did only have superficial injections. It was roughly 104 patients. And then there were 36 patients. Again, this is adding up to 140 patients. 36 patients had deep injections with or without superficial injections. And this wasn't the main endpoint for this study, and not really something that we were looking at initially. This was more of a post hoc analysis, but the response rate for patients who had superficial injections only was numerically lower. It was about 30%. But patients who did have visceral injections, again, with or without superficial injections, we saw their responses were actually numerically higher. They were 40% to almost 43%. So it's kind of thought-provoking there, and I think we still need to tease out why that would be different. The other analysis was looking at lesions which were injected versus lesions which were not injected. Amongst the 46 patients who had responses in the IGNITE trial, there was this um, there was this blinded radiology review where amongst each of the responders, up to 10 different target lesions could be assessed. So this was almost a total of 200 lesions that we went back and analyzed separately. 78 injected lesions, 119 non-injected. And what we saw was that for injected lesions, more than 90% of them would reduce by more than 30%, equivalent to a partial response. And amongst the non-injected lesions, almost 80% of these also decreased to 30%. So that really tells you that non-injected lesions could respond just as well as injected lesions. And we know that that's similar in terms of depth, duration, and overall kinetics. And then when you looked also at injections and non-injections between visceral lesions, we see the same thing. About 85% of visceral lesions that were injected would decrease more than 30%, and 65% of non-injected visceral lesions. So we think that this hopefully provides evidence that this therapy, even though it may be injected in a certain area, can have a more systemic or what you can arguably call an abscopal effect occurring away from the area where the therapy was injected. And the last thing then was looking at safety for visceral injections. A lot of these patients had either liver or lung lesions injected on the IGNITE trial. And we saw that amongst the patients getting liver injections, there were no big safety issues. But for patients who had lung injections, there were actually 8 patients, over 50 injections. There were 3 cases of pneumothorax that were reported. These were all low grade, grade 1 or 2. They all resolved within just 3 to 4 days. And there was only 1 patient that needed a chest tube, but this was all managed very easily, and that patient was able to continue. So we think the safety profile of this therapy is very good. Other than flu-like symptoms, fevers, chills after each therapy, they actually do really well. And so this looks like another promising therapy. There is an ongoing enrolling trial, that's IGNITE-3, which will look to randomize patients to RP1 plus nivolumab versus standard of care. That's enrolling here at our site at USC and also globally. So that will be very exciting to see how effective this intratumoral therapy approach might be for the refractory setting as well. So that's kind of the second, I think, hot area of research is intratumoral therapies, and I think the IGNITE study is a good example of one to follow in that space. I think that we have seen over the last, I'd say, 10 years at least, we've really seen the, we've seen dramatic shifts in the landscapes of almost every cancer, save 4 or 5, with the use of immune checkpoints. And PD-1, PD-L1, that axis, and arguably CTLA-4 have really changed things so much. They've been so effective in the metastatic setting, and then now they're moving gradually forward into earlier settings, certainly in the perioperative setting across multiple tumor types. So that's been tremendous, and I think pretty much many of our studies have looked at incorporating that angle into what we do. But I think it still remains to be seen, what do we do for those patients where those therapies alone are not super effective, or we eventually get to a point where we can only do so much to harness the power of the immune system. And I'm hopeful that we will still be able to find other approaches that similarly work on the immune system, but in complementary ways. And we've looked at a lot of other immune checkpoints now at this point, and some of them are showing good signals. But I think when we think about other approaches, cellular therapies, as mentioned, there's, in addition to TIL for melanoma, there's also a cellular therapy approved for the treatment of sarcoma. I think that is super exciting and points out even for rare diseases that might be very important. Intratumoral therapies, I'm hoping, is something that we'll continue to explore. but there's so much more bispecifics, and then of course always other personalized precision medicine-based approaches, targeted drugs that look at unique mutations. These are all things which hopefully will complement what we're doing. And my hope is that 4 to 5 years from now, we're using even less and less chemotherapy than before. But it's an exciting time, and I think even next year we'll have so much more to talk about.